apologies, he's not able to make it today due to some unforeseen circumstances. But then again, I'll try my best to share with you on project number 5 entitled Alzheimer's Disease Blood Biomarkers and Pathway Analysis using the Omics platform. This study, well, we have many number of researchers in the study, but basically we have got collaboration with the UiTM, UMC, we've got from UKM and IAU, and of course UiTM itself. Now, I guess being the last presenter on the topic of aging, I'm sure you will agree with me that there's dawn of a new demographic milestone as far as aging is concerned. And if you look at the local scenario, by 2054, I mean this was in the start a few weeks ago, by 2054 our nation is said to be a super age country, having about 21% of our population above 60 years old. And the impact of aging is definitely related to increase of degenerative diseases, including Alzheimer's disease. I mean, Alzheimer's disease is related or manifested by thinking, memory, and judgmental impairment. Now, this graph shows the not number of cases, but actually number of deaths. Okay, and what we can see is that the number of deaths by major diseases like heart disease, stroke, cancer has declined over the years. But it's otherwise for Alzheimer's disease. The number of deaths has increased over the years. And this so-called epidemic is definitely a problem for our age. What makes it more difficult is the understanding of the disease itself. How much do we understand about Alzheimer's disease? Now, it has been said that Alzheimer's disease is rather cloudy and is in piecemeal at the moment. This graph shows the treatment possibilities for Alzheimer's disease. But the red line shows the disease progression, while we know that, even this morning, Prof. said earlier that the current drugs can only treat the symptoms, not cure the disease itself. Okay? And we believe that this is mainly due to our inability to detect the disease at an earlier stage. Simply because the current point of diagnosis is towards the end. It's when there are signs and symptoms. But only if we could get biomarkers, identify what are the biomarkers at an earlier stage, this would really help in treatment of the disease itself instead of treating the symptoms. Now, over the last 15 years, there are no new biomarkers. Okay? What we have, here I'm talking about early detection, what we have are really the CSF, the cerebrospinal fluid, where we measure the tau and the amyloid proteins. So these are very invasive. CSF is invasive, and we also have got neuroimaging techniques for early detection of AD. But how many hospitals actually has these facilities? So the neuroimaging techniques are rather expensive. So we have the CSF and the measurement of tau and amyloid protein, which are invasive, while the neuroimaging techniques are rather expensive. So blood biomarkers are definitely an attractive option. So with that, the main objective of this study is to identify potential candidate blood biomarkers and elucidate the pathogenesis of Alzheimer's disease. Specifically, we have got 3 objectives. Our first objective is to sort of determine the omic profiles for Alzheimer's disease patients and also other subjects. Our second objective is to identify the blood biomarkers and sort of elucidate the joint pathways. Our third objective is to clinically validate these biomarkers. I'll go on to my first project on transcriptomics. In general, the framework of this study is divided into 2 phases. The first phase is basically, here we have got 180 subjects, 90 AD subjects, and 90 age match control. And the neuropsychological tests were done by our colleagues from UMC, and we did the profiling, the genetic polymorphism, transcriptomics, metabolomics, proteomics, and was we validated the data that we got. We identified a few biomarkers in our first phase, validated them. Like example for the microarray data, we used real-time PCR, and for the LCMS, we used targeted LCMS, and we also used NMR. For the cytokines, we actually did some knockdown studies for in vitro knockdown studies. We then tested these biomarkers in a different cohort. So generally, the demographic data for the whole study is something like this, where you can see that there is no significant difference in age, okay, between the control and also the AD subjects. And you can see that the MMSE tests and all, they are much lower in the AD, significantly lower in the AD as compared to the healthy subjects. The data was then statistically analyzed, and what you can see is that we actually chose 40 genes that were upregulated, 132 genes that were downregulated, and we chose a fold change more than 2 and p-value at 0.05. We then did the PLSTA analysis, and you can see a clear separation between the healthy and the AD subjects. Okay, and with the high sensitivities and specificity. We then validated the outcome of the PLSTA using the AUROC, and we found that the area under the AUC value is 0.88, which is considered that this biomarker is actually a reliable biomarker. Now, from the 172 genes, we actually selected these genes based on their correlation with the MMSE score. And what we found out, we actually also did from microarray data, we validated using the qRT-PCR for these several genes that we selected. And we then tested these validated genes. We selected 12 genes. We then validated these 12 genes using qRT-PCR in another cohort, but this is still in the phase 1. And here we have 60 subjects, 30 AD, 30 healthy subjects. And what we found is that our validation study showed very good correlation between microarray data and the qRT-PCR. And what is interesting is that these genes, the 12 that we selected, were differentially significant. These results are significant. They were differentially expressed between the healthy and the AD subjects. We then validated these genes in another cohort, okay? But this trial is still ongoing. We have 22 AD, control is 23. We have, at the moment, we have 8 MCI subjects and 7 vascular demented subjects. And what we found in our phase 2 of the trial, this was using the real-time PCR data for the 6 genes. What we found was that we were actually able to discriminate both MCI and AD patients from the healthy control. So these 6 genes, but up and 4 are actually significantly different. So we could actually discriminate using these 4 genes for validation study, but this particular study is still ongoing. And the pathways related to the microarray test are, related to AD is inflammation and lipid metabolism. So in short, for the transcriptomic results, we got a total of 6 genes that were successfully validated. And we will also, this set of genes, 4 of the 6 genes, we are able to actually discriminate both MCI and AD patients from the healthy controls. I'll go on to the metabolomics study. So the framework or the workflow for metabolomics and microarray is the same, but here we're using different platforms. Here we're using LCMS. We're using 2 platforms for the metabolomic data. The first platform is LCMS, and we're using 2 platforms because they are able to detect different metabolites. The sensitivity is different, so we use 2 platforms actually. Now, again, we use the data was And what is interesting is that 2 out of these 4 metabolites were actually also reported in the previous study. Because it's actually very difficult to get same metabolites to be reported, although they work on same AD and control for healthy subjects. But for the first time, we actually got 2 of the 4 metabolites to be reported in AD subjects, to be highly expressed in AD subjects. This is the validation study where we actually validated our LCMS kickoff results using targeted LCMS, but we did not do for all the metabolites, only the selected metabolites. And for the pathway analysis, what we found from the metabolomic study is that it was related to the single lipid metabolism. And all in all, we can conclude from the metabolomic study that these particular 4 metabolites are actually all related to apoptosis, and it results in neuronal cell death. Our second platform for NMR is for NMR, basically the PLSDA did not show a very good separation. We realized that LCMS was a better platform where we could see separation, but for the NMR we couldn't see very good separation. However, we found that we did the NMR permutation study, and what we found was that 2 metabolites were significantly upregulated in AD subjects as compared to the healthy control. So, in summary, for the metabolomics, we can summarize to say that the potential metabolites are associated with amyloid release. If we go back to the pathway, you can see that these metabolites actually cause neuronal release of amyloid. It results in apoptosis, alters amino acid and lipid metabolism, and results in neuronal cell death. Altogether, the non-overlapping detection of metabolites by combining the platform of LCMS and NMR, I think, is a good way forward, because we cannot depend on one platform to get the right biomarkers. This is a bit on the cytokine study. So for the cytokine study, what we always find is people look at the classical cytokines. So we actually look at the non-classical cytokines, and you can see that IP10 or CXCL10 is upregulated much more in AD patients when compared to healthy subjects. So what we did is that, and the agency value for CXCL10 is 1. And what we did is we wanted to understand the role of CXCL10, because the role of CXCL10 in AD is poorly understood. So we did a causal effect study using microglia and neuronal light cells. So here we used LPS to induce neuroinflammation. And what we found is that, yes, LPS is a good model to induce neuroinflammation, and CXCL10 is actually upregulated. And we did a knockdown study. We knocked down the CXCL10 genes. And you can see that the knockdown of CXCL10 in microglia cells resulted in the downregulation of STAT and NF-alpha B pathways, which are also related to neuroinflammation in AD. This study shows that we looked at calcium dysregulation, because calcium dysregulation is definitely implicated in the pathogenesis of AD. So we found that in cells, microglia cells that were knocked down, the CXCL10, where we knocked down the CXCL10, clearly shows much lower calcium dysregulation as compared to the LPS, where the genes were not knocked down. We also did some apoptosis studies, and it shows that the knockdown cells has got less apoptotic cells as compared to the positive control or the LPS microglia cells. But then again, these studies are actually ongoing. So for the cytokines, we can summarize that the levels of non-classical pro-inflammatory CXCL10 or IP10 can be used as a potential biomarker in our future studies in the phase 2. And what we can conclude is that we cannot use a single platform for the identification of biomarkers, and it will actually be good for us to integrate. We have not done that integration. We have got data from microarray, transcriptomics, metabolomics, yet we have data from proteomics. then come up with better hypothesis. And yeah, we hope to integrate omics data, and we need to work on larger sample size.